episode of the Second Count podcast. I'm joined with Joshua, who is an anaesthetic nurse and who's going to take over now and introduce himself.
Hi guys, my name's Josh. As Paul has said, I am an anaesthetic nurse working down in London. So I am basically the person one of the last people you'll see as you go off to sleep for your surgery. So
one of the questions I wanted to ask is how you actually got into that role as a nurse. So what made you decide to do that?
It was a weird one actually. So I went to uni up in Dundee, and I was doing my nursing course in adult nursing, and I was in my third year and I had a placement in theatres. And when I was there, the band seven, so like the senior charge nurse, turned around to me one day and was like, "You should work in theatres. Like, you seem suited to it. You actually, contribute as a student. Most students just stand in the corner and do nothing." I was like, okay, I'd never really considered it before. So they gave me the application. They literally held my hand through the whole thing and were like, "You need to do this. Come on, let's do it." The funny thing is, it was originally for scrub nursing. I'd never considered anaesthetics. It wasn't something I really knew anything about. I was kind of, at that point in time, more excited about being next to the surgeon, helping them with the surgeries. So when I went for my interview, it was the band seven of anaesthetics and the band seven of scrub, so two different people. And the band seven of anaesthetics said to me, "Just to let you know, we want you in anaesthetics." And it was basically because their reasoning for that was because I came across as being quite calm, but also confident at the same time. And I think that's something that's quite important, especially in anaesthetics, is you need to have a voice. So it's important for me to say to the anaesthetist, "Look, this patient is desaturating. This patient doesn't have an airway. We need to do, would you like this? Would you like this?" Whereas in scrub nursing, I kind of felt I wasn't able to do that as much. Whereas the relationship between an anaesthetist and their anaesthetic nurse or ODP is really good and kind of relaxed. So yeah, that's
I've been in theatres a couple of times as a student, and I've noticed the anaesthetist is quite chilled. Like he comes in, he does his job, and then he just sits there nice and chill. Then, but yeah. So
yeah, it is quite funny though that you say that, because like from the outside you look at them and you think, "No, they're just sitting there. They're not doing a lot." But actually, they're watching the monitor really closely. They're giving drugs that you don't even see them giving, and that's completely changing. Like, say for example, on the anaesthetic machine, the pressures have jumped. That's not going to alarm, but we're aware that's happening. So then we're giving, for example, like IV salbutamol to try and relieve the pressure in the lungs. We're checking the tube, but all that happens behind a screen. So everyone just presumes, "Oh no, they're just sitting there doing nothing."
Well, I've worked quite closely with anaesthetists because obviously I'm a student paramedic in like my last year now. So one of the big places where we get sent is theatres to intubate. And I remember my first time I was with this anaesthetist, and he just went, "Go on, do it." And it was the most nerve-wracking thing I've ever done in my life, because that patient is not breathing or got an airway, and he's like, "Just do it, just do it." And I was like, ugh. So how do you find the stresses of that? How do you cope?
Weirdly, I don't really get stressed anymore. I had a student the other day, and we had a patient. They were desaturating. We were struggling to get an airway in. It was a registrar doctor that was with us, and the consultant was kind of in the background. And it kept dropping 95, 92, 85. And I kind of turned to the anaesthetist and was like, the consultant, I was like, "Maybe you should take over now and let's come out and let's, go back to the bag and mask, because that was working fine. Let's re-oxygenate them, get them back up to 100%, and then try again." And my student said to me afterwards and was like, "You didn't look panicked." at all. I was like, no, it's just something I'm used to doing now. And I think even at the start, my mentor, when I started, said, there's no point flapping, because the moment you start flapping, you create an environment where nobody's able to work, and that's going to create more stress for everybody else around you. So I guess if I do get stressed at all, it's probably internalized, because I'm not tooting my own horn, because I feel so confident in what I'm doing. I'm never really worried about bad things happening, because I know that, for example, if we're bagging the patient and they're fine, we can always go back to that. And there's always plan A all the way down to D of things that we can do. And the worst case scenario is we have to go front of neck and then put a tube in.
All right, okay.
That's the worst case scenario. Like, if we can't wake them up,
Well,
we go front of neck.
that was going to be the next question. So,
So,
say you have put someone to
yeah,
sleep and you can't get an actual airway in.
yeah.
What is the plan then? Do you just bag them until they wake up, or what? Because paramedic mind, I'm thinking, okay, they're not coming round. I'm going to have to just bag them now until they do. So, what is it you would do?
Well, yeah. So, like, we've got like our set plan, and we go through it every single time. I mean, some anaesthetists, depending on how much they work with you, they get used to the way that you work, so they kind of know if you're capable or not, or if they trust you. So when we go off to sleep, we give the drugs, whether it be a gas induction or whether it be an IV induction, and then we'll bag them. During that time that we're bagging them, before we give any muscle relaxant, we're analysing to see, is that patient easy to bag? Because if they are, we know we can go back to that. So, for example, recently I had a patient who needed to be intubated immediately. So we did a thing called a rapid sequence induction, which is basically you go from patient awake, 30 seconds later, tube is in. And the tube wasn't passing. So we kept going back to the bag, tried a smaller tube, still couldn't get in, went back to the bag and mask, went and got a fibroscope, brought that in, we managed to get the tube in. So that's kind of what you have your first attempt intubation, then you have a second attempt, but you change something. So whether that be the blade, the laryngoscope blade that you're using. So if you're using a standard laryngoscope blade, you then go to a video laryngoscope. If that's then not working, you then try something like a bougie, which I think you'll probably use on the ambulances. And then we'll go to a thing called a stiletto, which is a bit harder. And then if none of those work, then we'll use a fibroscope, which is basically like an endoscope, but a lot thinner, so you can pass a tube over it. And again, if all those things don't work, then you go to a front of neck access. There is another step in there as well, where we use a thing called an eye gel, which I guess you'll have on the ambulances as well. So that's the laryngoscope. Oh my goodness, that's not a laryngoscope. That is a laryngeal mask, which kind of sits on top of the vocal cords. So that's also a possibility to go to. But because this patient needed surgery immediately, that's not a step we could really consider, because they needed to be paralysed, and we can't necessarily guarantee that we're going to be able to ventilate the patient well enough. So we had to make sure we got a tube in. One of the downsides with an eye gel actually is the risk of reflux, which you'll know a lot about as well. So we want to try and reduce that risk as much as possible.
So training-wise, obviously you've trained I'm assuming as a staff nurse, just a general nurse. What kind of extra training did you have to do?
Yeah. So it changes everywhere. But where I studied in Dundee, they do a thing called the NEST competency program, which should take between 6 to 9 months. So I did mine in 6, and that's basically you work in every single speciality. you learn about the different kind of procedures that you're going to do, and then how the general anaesthetic or the regional anaesthetic kind of matches up to each of those procedures. I think one of the hardest ones I found weirdly was actually orthopedics, because you're not just doing general anaesthetics, you're also doing spinals, you're also doing regional blocks sometimes as well. Because, say, for example, somebody's getting like their right ankle fixed, you don't actually necessarily need to give them a total block from like below your chest down. You only need the block really in the leg. So there are some
So when you
differences
say
with
when you
that.
say block, are you keeping them awake consciously, but just blocking pain from down? Okay.
Yeah, yeah. It is really cool that we can do that, because basically what we do is we put local anaesthetic around the nerves, which under ultrasound, you can find them around the veins and the arteries, and they actually kind of look like fibroscopic cables. You know how you've got like a cable and you've got loads of dots in the fibroscopic cable? That's what nerves look like. So we go, for example, say my arm, like you'll have loads of nerves all down here, but then up here you'll have like your kind of fibroscope cable before it kind of opens up. So we basically would then go in around about here or something, and then put local anaesthetic in, and then that will block the entire nerve all the way down. And then that means you can do procedures without the patient feeling pain. The difference is you can still feel touch. So some patients get a little bit freaked out about that. You know, they can feel something happening. So in those kind of cases, we'd give them like sedation. So we tend to give propofol TCI. So just a low amount of propofol in a syringe, and then it means that they're asleep, but they're still breathing. So we're not worried about their airway kind of stuff. Yeah, and actually looking back, when you think about it, it's kind of obvious. But when you're learning that, you're like, oh my goodness, why aren't they just asleep? Like, they're awake and they're talking. But
that's really interesting.
yeah.
I never thought like you could. Obviously, I've been in a few theatres, but they've all been completely asleep, intubated. The lot. I've never seen someone have like orthopedic surgery, because orthopedic surgery is rough. I've never thought to think they're
Yeah,
awake during that, but I suppose it makes more sense safer wise for the
it's
patient.
yeah. I mean, I worked in orthopedics when I worked in Aberdeen, and you'd get your 85-year-old trauma woman coming in for like a hip replacement. She is wide awake whilst they're hammering away at her leg, and you can hear it. And I'm like,
Like, sure,
I'd
you can
hate to be
feel
that
like the
patient right now.
vibrations. I know you can't
Like,
feel pain, but sure you can. Nah.
well, what's worse is like because they've got like a protective screening from like their chest upwards, and you literally just see the patient doing that, and I'm like, I'm glad we've given you some sedation here, because I
How do you
would
like manage
hate that
pain
so
though? So
much.
obviously you give a set amount of drugs, but how do you know that's the right amount for that patient? How's it? Could it wear off halfway through the surgery? Oh, right, okay.
Yes, is the simple
How would
answer
you
to
manage
that.
that?
The way we manage it is, so obviously the patient can't say to us, "Oh, I'm sore,"
True.
if they're asleep, you know. So the things that we look at is blood pressure, and we look at heart rate, because they're not technically asleep when you're intubated and in surgery. You're not sleeping like you do at night. Your body is aware of what's happening. So if the heart rate suddenly starts jumping up, then we know they're probably going to be in pain. So we'll give a bolus of fentanyl or morphine or something like that. And then if their blood pressure starts spiking as well, we also know that either they could be slightly aware of what's happening, or they are in pain as well. So then we'll give higher doses of anesthetic, or then we'll give more, like opiates to try and reduce that kind of pain. But a drug that is very, I always find this really funny. A drug that we use so much is paracetamol and ibuprofen. It works so well. And when I tell people that, they're like, what? But you can just buy it over the counter. I was like, it
So
is a
we give IV
ridiculously
paracetamol,
amazing
and when you've got a
drug.
patient who's got, like, say, a neck or femur fracture, and you go, I'm going to give you some IV para, they look at you like, no, I want like morphine, but they don't understand IV paracetamol is just as good, if sometimes better.
Yeah, because you don't get that kind of
Yeah, like the
side
respiration
effects of
drop as
being
well.
sick and like or nausea. It is a wonder drug. I still find it funny how Donald Trump started mentioning all that
Yeah.
stuff, and I was just like,
So
no,
going off the back of that,
no.
have you ever had anyone? It's a lot age-old question. Have you ever had anyone wake up during surgery completely? You hear the myths or like the stories of people waking up halfway through like a surgery and being conscious. Does that actually happen?
Um,
Okay.
yes and no. That's the political answer. The real answer, realistically, is nobody really wakes up. They can become aware, but we have a lot of things that we do to stop that. Obviously, back in the 80s and 70s, being aware during surgery was fairly common. But these days, we use um, what we call BIS, which is a monitoring strip that goes across the forehead and along the side of the head. And that basically monitors brain waves throughout surgery to basically check how aware a patient is. It's a really cool piece of kit, actually. And especially with the introduction of IV anesthesia, we need to keep an eye on how aware someone is or how awake somebody is during a procedure. On the flip side as well, when we give muscle relaxant, if a patient's becoming more aware and we've not got one of those strips on the forehead, they can't move to tell us. They can't even open their eyes because we've stopped that function from even happening. So there has been cases probably in the early 2000s where things like that have happened. However, again, going back to the monitoring side of things, if their blood pressure suddenly spikes and the heart rate suddenly jumps up, and then, you know, maybe the muscle relaxant starts wearing off and they start moving, then we give top ups. And the first thing that we do when they wake up is, do you remember anything? Were you aware of anything? If they say yes, that is a massive legal issue. I've never personally seen that happen. So I think I'm 6 years in now. I've probably seen best part of 6,000 cases. I've only ever had maybe 3 patients start moving on the table, but that was because the muscle relaxant needed topping up. It is so unbelievably rare. And what I do say to patients is, look, we've got all these measures in place that mean that we know what's going to happen. We know if you're going to start waking up. So it just doesn't happen anymore, which
Yeah,
is
it's good to know.
comforting, I
We
think.
touched on it before about training wise. How did you find training for yourself? Got moving from like general nursing to, because obviously you've done general nurse placements. How did you find that jump to
Yeah.
anesthetics?
It was really hard, like really difficult. So if we go back to November 2019, I had finished my nursing. I had done a 3-month placement on a renal ward. I walked out of that placement thinking, yep, cracked it. I'm amazing at what I do. I can walk in anywhere and I'll be fantastic. And then this sledgehammer comes from above and says, nah, you're really bad at anesthetics, so good luck. So in November, I remember one day where I left left work to go home. I just remember thinking, I can't do this. there's so much to remember. There's so many steps. There's so many procedures I need to know about. There's so many things that can go wrong. And I just thought, I'm not up for this at all. And that was I spoke to my mentor about it, and she was like, "Okay, take a step back. Let's go through the fundamentals again." And every question she was asking me, she was like, "Yep, that's right. Yes, that's what I would do. Yes, yes, yes." And I was like, "Okay, I do know what I'm talking about. So what's going on?" And I spoke to a couple of the anaesthetists about it, and they were like, "You just need to be more confident. You need to read up on a couple more things and study." And that's something I didn't anticipate at finishing my nursing, was the amount of studying that I had to do just to be able to then do anaesthetics. I think at one point I was finishing a 12-hour shift, I was going home, eating, and then I was probably studying for the next 4 hours. So I wasn't going to sleep until 1 a.m. And then I was going to work for 8 o'clock the next morning, doing another like 10-hour shift, for example, and then getting home and redoing it all over again. And my flatmate at one point said to me, "He was like, you're mental. Why are you doing this? Why didn't you just go to like a general ward and just do nursing, because you can do that anyway?" And I'm like, "No, I want to challenge myself, you know?" And I'm so glad that I got through that
So what?
hump,
So you've
if you
just
will.
touched on it. 10 hours,
So
10
yeah.
hours a day. What does a typical day look like from start to finish? Or is it all different?
Um,
Really?
every day is different, and that's something that I love about anesthetics. Um, there's no, you're not going back to the same patients as you do on a ward, because, the longest a procedure that I've ever seen happen is 14 hours, but we have shift changes. They're not going to be there when I come back in the morning. They're going to be in recovery, or they're going to be back on the ward or in ICU or somewhere like that. Um, so yeah, it's funny when I think about it, because I'll get up in the morning, I'll have my breakfast, I'll go to the gym potentially, I'll go to work, and then first thing that I do is I have a look on the allocation board to see where I am. So, for example, if I'm in obstetrics, so like C-sections and all that kind of stuff, I go into my theatre, I get the phenylephrine ready, I get some fluids ready, I speak to the anaesthetist to see like what the past medical history of all the patients is, and then that's it. Spinal procedure starts, baby comes out, close up, off into recovery. Same again for the next one, and then 4 or 5 later, you're closing up your theatre and then checking if everyone's okay. If they are, go home. So yeah, but then the next day, I could be in pediatrics doing an airway list, and then the following day, I could be doing a vascular list with a 75-year-old man who has smoked all his life, getting his leg amputated, and is like, "No, I'm going to keep smoking because it's coming off anyway." And I'm like, "You're
So
driving me
true.
crazy, but
It's
fair
so,
enough. You
so
can do whatever you
true.
want."
It's like COPD patients.
I had a patient. I actually had a patient. When was it? Last week, and he was drinking like 5 bottles of whiskey a week. He has like 40 cigarettes a day. He was getting his foot amputated, and the vascular surgeon turns to him and is like, "Have you ever considered quitting smoking?" And he was like, "You can write off. I'm never stopping smoking." And I'm like, "Fair. You know what? Fair." And the surgeon was like, "Yeah, but we'll get the rest of your leg chopped off." I was like, "So be it. I love a cigarette." And I was like,
So true.
"Okay."
You got like COPD patients I go to, and it's like, you've ever thought about quitting? No, they're hardly breathing. It's like, it help, but each to their own, isn't it? Each to their own. But
I know. It always worries me though when you've got your COPD patient and they're smoking away and they've got their oxygen
Yeah,
tank turned off next to them, and I'm like,
the amount of
bit of
houses
a
I've been in
hazard
where
there,
that's a
mate.
thing, and it's like, but to get home oxygen, you have to prove you've stopped smoking. So they stop smoking for like 6 weeks, get the oxygen, just get back smoking, and don't tell anyone. So you walk into a potential house where someone there sat there smoking with an oxygen cylinder next to them, and with I've been into someone with nasal cannulas on smoking, and no one just, I'm like, put that out,
Oh
put
my
it out.
goodness,
I
no
won't come
way.
in until you put your cigarette out. But
Well,
yeah,
yeah, because otherwise, boom.
so amputated limbs. What? Just speaking of that, what happens to them after surgery? Are they just are they just medical waste?
That is pretty much, yeah. You put them in a yellow bag. To be honest with you, I'm not completely certain because that tends to be the scrub nurse's kind of thing. Um, from what I understand is it goes into a yellow bag and then it goes into a specimen box. If it then needs to be looked at or biopsied or whatever, they'll take that to the lab and that will get done. If not, it tends to get incinerated. Um, did also have a patient a
I was
couple
going
of
to say,
years ago ask for
can
the
you ask for
leg
your
back
limb back? No,
to take
is that not a
home.
thing?
No, no, because this patient was like, "I love that leg. Can I bury it?" And the surgeon was like, "No, no, you can't."
Oh God.
So yeah, I do
I was
meet
gonna say,
some
I've been in
very
theatres about
interesting
four
people,
times on placements.
but
I'm going back quite soon, actually. I always find as well, though, why is it so cold? How do you cope with the cold? It's so
it
cold.
is it is so like I'm sat here shivering and I'm pretty sure it's 18 degrees in here, but like in theatres the other day it was like 15 and everyone is like
Is there a reason for this?
but it's
Okay, that makes
it's to
sense.
reduce infection risk. So yeah, like the colder
Yeah.
the air, the less likely you're going to have bugs going around. But then it's funny because in pediatrics and obstetrics, those theatres are really warm because you don't
Mm.
want the babies to get cold. And I did ask the surgeons this once, and they said having a patient who is a good temperature at this age is more vital than reducing the infection risk, which I thought was
Mm.
kind of a contradiction in itself because surely you don't want infections in children. But then if you have a patient go really, that's something I might touch on actually is in pediatrics, patients go off really, really quickly, but then they come back really quickly. So I guess if you've got a warm environment, you're kind of reducing one of the things that could go wrong quickly. So
Mm.
I kind of understand the point of view, but there also has been occasions where the theatre has been shut and we can't do a case because it's too cold, um, which again is
Yeah.
fair enough. I mean, if you've got a surgeon literally like shivering over the patient, I don't think that's going to work
One
very
more
well.
question. I've just been sat here thinking, facial surgery or any sort of like surgery on the throat or anything. How do you go about intubating or keeping someone sedated that way, or breathing for themselves?
So unless it's like minor stuff on the face, we would never really sedate a patient for kind of like max fax or ear, neck, and throat surgeries. So it depends on the surgery for a start. So there's some procedures where you'll put a tube straight in, and that's for like a jaw kind of surgery. And then what they do is they then, because they'll need a tracheostomy because they're doing such big facial surgery, we'll go off to sleep with a endotracheal tube, so a tube that's going down through the mouth. And then we'll open up here to do the tracheostomy. We'll see where the cuff is on the tube, bring it back, put the tracheostomy in, and then connect the tubing on, and then we'll ventilate from there downwards. For other kind of surgeries that don't require that kind of invasive procedure, there's kind of three options. So I mentioned the endotracheal tube. So you also have a reinforced tube, which means that no matter what you do with it, it's not going to kink. So you can have it off to the side if they're doing it on, if they're doing the surgery, for example, on the right side, then you can have it off to the left. Or what we also do is a nasal tube, which is quite cool. So it's not as hard as the normal ET tubes that you'll see, because the normal ET tubes are quite hard plastic. So these ones are softer, and basically we use a fibroscope to go in through the nose, down through the cords, and then we pass a tube with the fibroscope down in through the nose, and then have the tube pointing up over the head, which is quite funny because I was in Max Fax yesterday doing exactly that, and all three of my patients had nasal tubes with a fibroscope and then back up over the head. So it's quite funny that you asked that.
Well, we're coming close to the end now. Josh,
So,
thank you so much for coming on. Where can people find, because I know you're quite active on social media at the moment, where can people find you on your Instagram or TikTok?
So my handle on both of them is just Nurse Josh. So ANAES Nurse Josh. So yeah, I'm doing like a day in the life of an anaesthetic nurse every day. So it's people find it quite interesting.
Quite rapidly, quite quickly on Instagram. I've noticed, yeah,
it's actually kind of scary. I started that up a week after my TikTok, and I've almost got the same amount of followers on.
Well,
on
anyway,
Instagram.
Josh, thank you so much for coming on.
Thank you very much.